It's long been appreciated that benzodiazepine use is associated with delirium, but the nature of this association has been unclear because these agents are commonly used to treat delirious patients. Recent data evaluating 11 covariates identified lorazepam as an independent risk factor for the development of delirium. Nearly all patients who received more than 20 milligrams lorazepam for 24 hours subsequently developed this diagnosis. However, drug amount may not be as important as drug effect. A recent study of risk factors for delirium confirmed previous observations but found no association with benzodiazepines unless these drugs resulted in even brief periods of coma. It may be prudent to limit indications for benzodiazepine sedation to patients with anxiety, seizures, and alcohol or sedative withdrawal. Avoidance of deep sedation, with the exceptions previously noted, may be prudent. This GABA agonist is easily titratable and offers consistency in both onset and offset. In contrast to most other sedatives, the pharmacodynamics of propofol are not appreciably altered by organ dysfunction. Trials indicate that long-term ICU patients remain ventilator-dependent longer, 8.4 versus 5.8 days, and stay in the ICU longer, 22.5 versus 19 days, when they are administered intermittent benzodiazepines compared with propofol, despite use of identical sedation titration goals and daily sedation interruption. Propofol has no analgesic activity and is not reliably amnestic when used in the lower doses typical in the ICU. It causes respiratory depression and lowers vascular tone. Twice-weekly triglyceride levels are recommended to detect lipemia that may be related to, but is not necessary for the diagnosis of propofol-induced pancreatitis. Hypertriglyceridemia may also be a hallmark for the propofol infusion syndrome. The propofol infusion syndrome is a rare but extremely lethal aspect of propofol therapy. Initially recognized in the pediatric population, it is characterized by hemodynamic collapse, bradycardia that quickly transitions to asystole, metabolic acidosis, rhabdomyolysis, and lipemia. The pathophysiology of the propofol infusion syndrome is not well understood, but it may involve impaired fatty acid oxidation and a direct effect on oxidative phosphorylation through mitochondrial toxicity. It appears to be related to dose, greater than 80 mics per kg per minute, and duration, longer than 48 hours. Although several recent reports have described it in patients treated with usual doses and within hours of drug initiation. Patient-specific risk factors for developing propofol infusion syndrome include acute neurologic illness, sepsis, systemic inflammatory response syndrome, or SIRS, vasopressor dependence, and corticosteroid treatment. Because there is no known effective treatment for the propofol infusion syndrome, it is recommended that propofol be immediately stopped when it is suspected. This alpha-2 agonist sympatholytic sedative agent is unique because it has little or no clinically significant effect on the respiratory drive. It provides sedative, anxiolytic, and morphine-sparing activity while allowing assessment of patient mental status upon stimulation. Because it permits patient awareness and does not offer amnesia, it is not an appropriate sedative choice for those requiring deep sedation or those undergoing therapeutic paralysis. This drug is extensively metabolized in the liver and requires dose adjustment in the setting of hepatic dysfunction. Approved dosing guidelines for dexmedetomidine in 2008 allow use for no more than 24 hours at doses of up to 0.7 mics per kg per hour. Preliminary reports have documented that as many as 20% of patients require higher doses and longer infusion durations may be safe. Preliminary data suggest that dexmedetomidine may be associated with a lower frequency of delirium since it does not affect GABA receptors or have anticholinergic properties. But dexmedetomidine is not without its own concerns. The sympatholytic properties of dexmedetomidine result in predictable hemodynamic effects, a reduction in blood pressure and heart rate. Lowering the dose or discontinuance of dexmedetomidine is indicated if these hemodynamic effects are deleterious in light of the patient's condition. Occasionally, the administration of fluids and vasopressors, as well as cardiac pacing, may be required. Potential risks associated with long-term use, such as rebound hypertension and tachycardia on discontinuance and adrenal insufficiency, have not been. Delirium is an acute change in cognitive function that typically exhibits waxing and waning during the course of the day. Central to the diagnosis are features of disorganized thought, together with an altered level of consciousness and inattentiveness. Other features of delirium are listed here on this slide. There are at least 3 subtypes of delirium: hyperactive, hypoactive, and mixed. The hyperactive variety is easily identified by patient behaviors such as restlessness, agitation, aggression, and paranoia. It accounts for less than 2% of delirious episodes. More than 40% of delirium can be characterized as hypoactive, identified by patients who exhibit withdrawn, quiet, and paranoid behaviors. More than 50% of delirious episodes are of the mixed variety. The neurobiology of delirium has yet to be fully described, but it's probably associated with many factors, including disruption of the delicate balance of various neurotransmitter and receptor functions, as well as the release of inflammatory cytokines, increasing blood-brain barrier permeability and altering neurotransmission. Some of the risk factors for delirium are listed here. It should be appreciated that 30% of cases of delirium have a pharmacologic basis. More than 100 drugs have been characterized as delirogenic, and most have been shown to affect CNS neurotransmitter or receptor function. Prototypically, these agents have overt anticholinergic activity, but many affect choline receptors in a subclinical yet measurable fashion. The potential for additive anticholinergic burden with multiple drugs and subsequent development of delirium has been demonstrated. Because it is possible to lower the incidence of delirium in non-ICU settings by at least 40%, preventative strategies should be routinely offered in the ICU. See the slide for suggested components of preventative strategy. Once delirium has been identified, the mainstay of treatment is simultaneous identification and correction of potentially physiologic causes. For example, hypoxia, hyperthermia, hypercarbia, pain, acidosis, hemodynamic instability, infection, and the control of potentially dangerous behavioral disturbances as well. Because delirium is thought to be predominantly an issue of an imbalance of CNS dopamine and choline, these neurotransmitters and others, GABA and norepinephrine, are prime targets for pharmacotherapy. There are no data in the critical care literature to guide the treatment of hypoactive delirium. In fact, literature on ICU delirium treatment is wholly limited to a variety of case and observational reports and one small comparative trial. Furthermore, there are no prospective ICU data suggesting that therapy reduces the duration and severity of symptoms or improves any other clinically relevant outcome. Despite this, intensive care practitioners commonly prescribe some sort of drug for these patients, typically from antipsychotic agents such as haloperidol to atypical agents, quetiapine, etc., and benzodiazepines, of course.